Afternoon, ladies and gentlemen. It is my pleasure to talk to you about atopic dermatitis and infectious, and I will try to give you some aspects, some new aspects. These are my conflicts of interest. I'm advertising my book, and everybody knows that atopic eczema is complicated by viral, fungal, and bacterial infections. This is known for 1.5 centuries. And what's new, I will start with general aspects and then focus on bacterial, namely Staph aureus mostly, and viral diseases. There's an interesting study about early life infections. You all know the hygiene hypothesis tells that early infections, early immune stimulations, living on a farm with a lot of dirt is protective against allergy. This does not seem to be the case in eczema. This study shows clearly that early life infections enhance eczema. This was done in Taiwan with 5,000 patients and 16,000 controls. And infectious diseases, skin infections, and systemic antibiotic exposure before the diagnosis AD was made were independently associated with this disease. The risk of herpes virus, serious and opportunistic infections also has been studied in a group in Baltimore, in USA, in a tremendous number of cases, almost 1 million AD patients, 400,000 children, 600,000 adults, and almost 2 million controls. And children and adults, they had a 50% greater risk of herpes, also of varicella and cytomegalovirus. And also opportunistic infections were associated with AD, especially with severe AD. So there is a close connection. And Th2 obviously is not so good in the defense against bacteria, viruses, and fungi. The cutaneous microbiome is en vogue, and it has been studied in many diseases, but especially also in eczema. And this is a citation classic from Heidi Kong, showing in these different colors the diversity on the left side on normal skin, and in the center, the only purple Staphylococcus aureus growth on the lesional skin during a flare. So this is very characteristic, and this is how those children look like, and we know them all. They are suffering tremendously. And Staph aureus is found everywhere, not only on the lesions, but also on non-lesional skin. And it can be colonized in multiple virulent strains. Some individuals produce IgE antibodies, and there are polymorphisms in the toll-like receptor. There is a dysbiosis in the skin microbiome in AD, and it is site-specific over different body sites. And this was studied in this Scandinavian group, 14 well-defined sites in 10 patients with AD and 5 controls, and they found clear differences. And it's a bit confusing, but you see on the upper part, green is Cutibacterium acnes, and red is Staph epidermidis, and purple, violet is Staph aureus. And in the lower part, you see, according to similarity, are all the different taxa arranged. And you see that purple is Staph aureus, red is Staph epidermidis, and underneath in the headings, red is atopic dermatitis, black is healthy control. You see there is a complex interaction, but there is clearly some difference between the eczema patient and the controls. And these are viruses from the same group, staphylococcal viruses, phages, and they go down to here. And up here are propionic bacterium phages. This is a non-lesional skin, and this is lesional skin of Staph aureus. Let's come to viral infections now, since we have looked at the phages. Eczema herpeticum, well known, and it can be terrible and life-threatening when there is encephalitis. Due to the studies from Alexander Wollenberg, we have learned that there is a lack of plasmacytoid dendritic cells, and then this exacerbation occurs and makes the individuals sick. One has also known this from smallpox vaccination as eczema vaccinatum, and therefore eczema and atopic patients could not be vaccinated, and they were not allowed to go to USA because vaccination was obligatory. This was before 1980, and you remember this time. And then the Professor München, Professor Stickel, developed a vaccine which is safe also for atopics. He could have got the Nobel Prize, but at the same time, the smallpox were eradicated, so nobody was interested anymore. But there are two places in USA and in Russia, in Novosibirsk, where there is still old variola vera virus, and people are afraid of bioterroristic attacks. And therefore, they try to use this modified virus, which is safe. And we were proud to be in this study in atopic individuals with rhinitis and with eczema. And to make a long story short, this vaccine is safe, and there were no signs of exacerbation or eczema for over 196 days. So we hope we don't need it, but it would be there. There's also eczema molluscatum. These are also pox virus, molluscum viruses. And this little boy, he had Coxsackie virus infection and got an exacerbation of eczema. And this is not so well known, but we call it eczema coxsackicum. And to put everything together, people should get the vaccines like every normal. Here, people who are vaccinated according to the recommendations have a decreased risk of developing atopic dermatitis in the first years of life. So all children with eczema can and should be vaccinated like normal children. One last word on COVID-19, because this is all of interest to many, many doctors and people. And I can imagine that you have the same problem in the office with questions. And there are several guidelines and position papers here, one of the European Academy of Dermatology regarding the immunomodulatory treatment and no contraindications for immunomodulators, systemic or topical. And also biologics may be continued with a 1-week interval vaccination. This is very important for the practice. And maybe methotrexate could decrease the efficacy of the vaccine, but not the safety. So this is very important for our daily office. And interestingly, dupilumab, a study by Amy Paller, does not lead to increased rates of infection in children and adolescents. And one nice case report shows a little boy with severe atopic dermatitis who got finally dupilumab, and then he had also warts, and the warts resolved unexpectedly after 8 weeks. So this was a nice side effect of this dupilumab. And the most frequently asked questions in my office of eczema patients, doctor, can you write me a certificate that I don't have to get, or should I get this COVID-19 vaccine? It's so dangerous and I'm so allergic. Again, no, atopic dermatitis is no contraindication for COVID-19 vaccine. And there are very rare exceptions, namely life-threatening allergic reactions to earlier vaccinations, anaphylaxis to possible ingredients of vaccine, or anaphylaxis together with mastocytosis. There we are very careful, and maybe one should do this under pre-medication. But in fact, almost everybody, and really everybody, can get the vaccine and should get the vaccine. With this, I come to the end, and there is a very recent case report from Napoli in Italy, the group of Professor Argenziano. They had 2 patients with severe AD, and they were frustrated with cyclosporin and all the classic immunomodulatory treatments. So they put them on the list for dupilumab. And shortly before starting, they became positive for SARS-CoV-2. And so they said, let's wait 4 weeks. And one had no symptoms, the other one mild symptoms. And after 4 weeks, the PCR became negative. The skin had improved so dramatically that there was no need to give dupilumab any longer. And they remained stable over many months now. So this is a recent publication. And I'm wondering, in the JNEV, I'm wondering whether other people will observe similar things. And with this, I come to the conclusions. Microbial infections influence the development and the clinical course of the eczema. The patients with AD are more often affected. The cutaneous microbiome differs between the patients and normals and with a reduced diversity. Viral infections can dramatically exacerbate the eczema. A new subcutaneous anti-smallpox vaccine would be available in case one would need it, and it would be safe for atopic individuals. And all patients, also AD patients, should get all the necessary vaccinations, and also the COVID-19 vaccination can be done in atopic dermatitis without increased risk. With this, I'm at the end, and I want to thank you for the attention and all the former co-workers and colleagues who helped me to prepare these lectures. Thank you very much.